Thank you all for joining the session today. I'm Sarah Zeidler. I'm the Executive Director for the Stoddard Cancer Center here in Des Moines, and I am also a board member of the Iowa Cancer Consortium. And before I introduce Dr. Dickens, I just want to thank the consortium staff for putting on a really awesome event. This is my first in-person conference in a couple years, and it's going to be a high bar for anything that comes after. So, all right, so I have the pleasure of introducing Dr. David Dickens. He earned his Bachelor's of Arts degree at Oberlin College and his medical doctorate at Upstate Medical University in Syracuse, New York. He completed his residency at the Children's Hospital of Pittsburgh and fellowship at Cincinnati Children's Hospital Medical Center. In February 2019, Dr. Dickens became a clinical professor at the University of Iowa's Stead Family Children's Hospital as the Dance Marathon Endowed Chair in Pediatric Oncology, Clinical and Translational Research, and is currently serving as the Interim Division Director of Pediatric Hematology, Oncology and Transplantation. Dr. Dickens holds numerous institutional and national leadership roles to support the needs of pediatric cancer patients and hopes to continue to collaborate strategically with national colleagues and organizations to further the needs of pediatric cancer patients and their families. And he also is a musician and a magician, which I found very interesting and I'm sure makes him an exceptional pediatrician. So welcome, Dr. Dickens.
Thank you. I tend to wander when I walk, and this is a smaller audience, and so hopefully the cameraman's okay with that. Can you just thumbs up if that's okay? Perfect. Being a later in the day speaker is a big responsibility. It's post-lunch. People are looking forward to their travel plans. People are split up. So I'm going to try my best to keep everybody engaged and tell you all about pediatric cancer in about 30 minutes. In 12 content slides. So the slides are a little bit dense, so when you see something up there, just hang tight. I'm gonna walk you right through the whole diagram so you don't have to focus on small little letters. I'll explain it all. So I'll start with a story also too, because today listening to all the different speakers reminded me of this very important story, which you're all welcome to share. So about 10 years ago, my wife started a family tradition. I don't know how it came to her, but it's been great. My oldest child at the time was about preteen, 11, 12 years old. My youngest would have been about 5. I have 4 beautiful children in total. I have 5 if you count the ugly one. So I have 5 kids, so it takes a while, and there's birthdays all around. Is this being recorded? Yes, it is. But if it's not on TikTok or Instagram, they won't see it. YouTube, they don't do that. That's for old people. So on a child's birthday, everybody goes around the table and says at least one nice thing about that birthday child, including the siblings. And you can't repeat anything that somebody before you said. So everybody learns quick to go first because they don't have to come up with anything that's new or creative. That's a little bit relevant for me today because there was a lot of people who spoke who said, you'll see it's almost omniscient. Some of my content is very similar to what you heard, and I'm modifying what I have to say according to what I'm hearing, just like these birthday kids. But the best twist, if you incorporate this into your family flow, is after everybody goes around and says something nice about the birthday kid gets to go back around the table and say one thing that their sibling can improve on. It is delightful. So what is a pediatric cancer doctor doing here in the context of the Iowa Cancer Consortium? Because one thing to establish up front is pediatric cancer and adult cancer are different things. I heard a question came up in the last session about, help me explain why precision medicine is important to adults and give me an analogy. Well, I lived in Michigan for 17 years. It's easy. And you say, when you have a part of your car broken, you can't go to an auto parts store and say, my car is broken. Can you fix it? They're going to ask you the year, the make, the model, so they can get you the right part. And the parts that break in pediatric cancer are different than the parts in adult cancer. So this is from SEER data, the top types of cancers that are seen in men and women adults. And if you look at those top, that's probably the top 10. Out of those top 5, none of them in pediatric cancer gets a slice of the pie. Not a single one of them. So the breast and prostate and colon, we just don't see those types of cancers in pediatrics. In our pie, the biggest piece is leukemia. The second biggest piece is brain tumors. You just put those two together, that's almost half of all of our cancers. And those types of cancers don't even show up on the list of the top 5 in the adults. We are in some ways talking about a completely different problem. The numbers are smaller, and we heard a little bit earlier in the day from Dr. Richardson that when you're dealing with public health issues, people are looking at numbers, but that's not the whole story. What I heard Dr. Richardson say, this is about impact as much as it is about numbers. And when you're dealing with children with cancer, if the average age of leukemia is 2 to 4 years of age, you are looking at decades of life years saved. And that is where, in one ways, we're different. But those numbers average out to about 100 to 1. So every 100 adults that are diagnosed with cancer, 1 child is diagnosed. So that's about the scope of the problem, and that's nationwide. Anytime I throw a national data out, usually you can divide that by 100, which just means you move the decimal point over 2 when you're trying to think about Iowa statistics relative to the rest of the US country. Here is one fact that feels like reminds me that the Iowa Cancer Consortium is not the Iowa Adults with Cancer Consortium. It's the Iowa Cancer Consortium for all constituents of the state of Iowa, including children. And we do have a focus and strengths in epidemiology. But over on the left side of that graph is incidence rates over time. So the further that line goes out to the right, when it goes up, that means more children are being diagnosed now than they were 30 years ago. And used to be back in the 90s when I started my training, people were wondering about technology. Maybe the technology is better and different. We're finding more cancers. But those trends have continued. And it's continued for all the different races. Each color line is a different ethnicity. We are doing better at mortality rates. The right curve, I'm going to say something about mortality, but we are doing better about less children dying when they get diagnosed with cancer. Roughly speaking, 85% cure rate if you average everything across the board. This is kind of like a heat map of the United States. This is one of the few Iowa-specific slides I can find with regards to the incidence of cancer. So there's a picture of the United States. People in this audience are probably the one group that I would not need to put an arrow on which rectangle Iowa is, but in other parts you do have to point. The darker blue states have a higher incidence rate of cancers, and the white is the least amount of cancer incidence in children. And on that very top right graph, that is all the different kind of cancers combined. And so as you see, Iowa is kind of like a medium to dark blue. That means that we are slightly more, have a slightly higher cancer incidence rate than the national averages. But these other maps represent specific types of cancers, leukemias and brain tumors. And in some categories, we have, we're doing better than the national averages, like that top left is leukemias. And then right beneath that are brain tumors, and we're doing worse, much worse than the national average. And in fact, we don't know why yet. So some of the work that I can see combining with the mission of the Iowa Cancer Consortium is to answer these critical questions that I get asked by every patient. How did this happen? Why did this happen? How many people in this room have children or grandchildren less than age 18 years? Show of hands. And nobody knows who I am, right? Nobody's ever met me professionally in this room. You know why? Why do you have the good fortune of not knowing me in my professional life? Nobody knows. Nobody knows. That's the work that we can do. Moreover, even though these numbers, the mortality rates are improving, the significance of pediatric cancer is this. This is a graph that represents all causes of death due to disease in children. This came out in 2018. It was the latest publicly available information from the CDC. And as you can see, that more children die of cancer than any other disease in the United States. Moreover, what I tell people is you can add all the other types up, and it's still less than the number of children who die because of cancer. So even though we have high cure rates, even though the mortality rate has dropped, this is what's going on today. I loved how earlier we were broadening the definition of cancer prevention. It's not just about cancer prevention. This is where I think historically it's been a struggle to fit peds into this mission. Because what am I supposed to do when people tell me, what happened? Why did my kid get this? I don't know. So what do you do with that information? But it's not just about cancer prevention. There are some ideas that I have how we can move forward with that. But we're really talking about 4 different domains. Somebody on the board had recently described the vision of the Cancer Consortium not as cancer control and prevention, but as reducing the burden of cancer in the state of Iowa. And when you think about it like that, it broadens the perspective, because there is a huge burden when you get diagnosed that we might have strategies to help reduce for families that we meet. So the 4 general categories are the classic prevention, and that's hard to deploy in pediatrics, but I have one idea. Early detection, another idea. Diagnosis and treatment, I'll show a slide on that, and survivorship issues. You think about that, now we can have some ideas about how pediatrics fits into the Cancer Consortium. I am not going to steal the thunder from the next person who's coming, so I am going to cut off this slide, which represents known causes of cancer, not just specific to pediatrics, but in the human population, and just focus on the very bottom issue. And the bottom issue, and we kind of heard about this in our last presentation, was genetic screening for pediatric cancers. Maybe we're not quite there yet. I hope to provide evidence to suggest that we are there yet, and we need to start focusing on genetic screening, because roughly 1 out of 20 of my patients will carry a predisposition for a disease, a type of cancer that hits children. It's not often, but the impact, the potential impact of that might be enormous. So here's a study that Harvard did, and I read this paper about 20 times to try and translate what these ultra-intelligent people were trying to say, and I will do my best. If you're interested in scrutinizing what these people had to say, I would challenge you to read that and understand for yourself. But here's how I would boil this study down. So they were looking at what happens, they modeled, they just like put in some average numbers of situations. They asked a question, what if we did this? What if we just started screening siblings of children who were found to have one of these genetic predispositions? So that's typically right now what happens. Somebody gets diagnosed with cancer, the oncologist says, this seems kind of strange. I bet you this kid has a somatic or a mutation in their entire body that led to this situation. You find the test in the child, then the parent's next question is, does my other child have it? So that's what this testing was doing. It was going back into the siblings and asking the question with mathematical modeling that I could not completely understand despite my best efforts. What would that mean? So they really looked at 11 genes, just 11 genes that would cost roughly between $100 and $200 to run. These were common genes that are known to cause pediatric cancers and actually had a pathway where we can screen the asymptomatic sibling, which is currently something that we are not doing. So there's roughly 3.7 million newborns, and they assumed in this model that each one would have one sibling at least. So they do all the math and they figure out of that 3.7 million, how many of those would have one of these predispositions, and then what if we tested the sibling? And what they found is they would be able to reduce the amount of cancer deaths in pediatrics by 52%, just from early detection. So if you boil those numbers down to the state of Iowa and envisioned a way that our state would run these 11 genes, it would probably save somewhere between 1 and 2 lives per year in children. It was hard. They had this ratio called the incremental cost-effective ratio. I couldn't understand how they did it, but basically it's just like you're going to spend some money to do this test on everybody, and then you're going to potentially spend money on the screening tests, and then you would potentially save money in the treatment. And these were very different genes and very different diseases, so it was very variable. But at their maximum, this sort of ranged from being a cost savings, so it was much cheaper to do the testing than treat the disease, and in some cases it was vice versa, to the maximum of about $52,000 a year per life year saved. So there is a potential way that we could save lives in children with screening. The other reason why I think it's important to have pediatricians engaged, by the way, is there any other pediatric healthcare provider in here? Okay, one. Maybe there were some in the other room. One. So I looked at the standard pillars for cancer screening in adults. And of course, we have smoking. So I found this online. If anybody has updated data, let me know. But the smoking cancer rates in Iowa are about the same as national, about 6% of children who admit they're regular users of cigarettes. And then on the right side there is vaping. So e-cigarettes are about 20% of high school students. This was a couple years ago, I think this came out. About 20% of high school students admit to regular using of vaping. In other studies, up to 90% of smokers report that their brain got hit with nicotine for the first time as a kid. 90%. That sounds like a pediatric problem. Smoking prevention is better than smoking cessation, because once nicotine hits your brain, that's a lot harder. If it never hits your brain, that's easier. So we've got to be talking about to pediatricians. Sun protection, that starts as a pediatric behavior. I've never put sunblock on any of my 5 kids and had them not screaming, so I don't know why that kid's smiling. But people don't do it because it's hard. It's just a nuisance. You get sand, and it feels like sandpaper's running on them. They cry, it gets in their eyes, and they complain. Pediatricians need to be sending this message as well. Obesity, this is a heat map for obesity. The state of Iowa is kind of mid-ground. Those green and blues are a little bit less obesity rates, and then the yellows and the reds are a little bit hotter with more obesity rates. Winds up being somewhere in the ballpark of 15 to 20% of our children in the state are obese. And obesity and lifestyle changes, lifestyle habits are established when you're a child. And pediatricians need to get engaged. Not being obese, training your kids not to be obese is easier than treating obesity. And of course, there's HPV. HPV vaccines, this is an ad I found online from Iowa. That's a disease that we vaccinate as children. So there are other important mechanisms for cancer prevention, but here's 4 major categories that a pediatrician or a healthcare provider or a family practice doc should have an enormous influence on, and there ain't a single pediatric provider in this audience. Also, here's precision medicine. Nobody asked me my definition, but I'm going to get to it. So on those diagrams, those 4 diagrams, we're on diagnosis and treatment now. Burden of pediatric cancer. The burden of pediatric cancer sometimes is from our treatments. And our standard treatments are really 3: surgery, radiation, and chemo. And that comes at a price. The evolution that we're in, that's how I define precision versus accuracy. So the center of our target is curing cancer. And you can be really precise and give somebody a precision medicine that blocks a specific mutation and doesn't cure cancer. Precision just means that you were very consistent with something. But if that something isn't your target, it doesn't matter. Accuracy means that you were both, precise, and accurate means you were hitting the target right where you wanted to hit. So chemo is accurate. It'll kill cancer, and very successfully. But it's not very precise. So we need both. Personalized medicine means you take all of your individual information and then you plug it into the formula. That, to me, is personalized medicine. Precision medicine is you just find something and you target it. But it doesn't matter if you're off. The hope and the promise of that approach is it's less toxic, reducing the burden of cancer. Survivorship, the last bubble. We heard there were 22 million cancer survivors in the US. So the question in front of you is, out of the 300 million, 300 plus, 330, something like that, million people in the US, how many are survivors of childhood cancer? So I'm thinking this is probably plugged into that 22 million. And so how many are there estimated to be right now, 2022? That number is about 500,000. So there are 500,000 people walking around the US who had a history of childhood cancer. And how are they doing? So St. Jude's does a lot of research in their lifetime cohort. It's called their lifetime cohort. Have studied this issue. And they've asked these questions. How many cancer survivors experience at least one severe chronic health condition? At least one. And severe means it's disabling, life-threatening, or it already killed you. It's got to be in one of those categories. So what would you estimate that number to be? 96%. 96% of cancer survivors in the study had at least one. That sounds like a lot, but the question was, well, how often do people who didn't have cancer have a severe chronic health condition? So they did a cohort study, and they compared those rates to age-matched, gender-matched controls in their community. And so on the flat axis, the x-axis is age. So the further that goes off to your right, the older those patients get. And at age 50 years old, that bottom line, that dark line, it's actually dotted, it's hard to see, it's black, is the number of cumulative healthcare conditions in the control population. So the answer to the question, this is now not percentage, this is the cumulative number of healthcare problems regular 50-year-olds have. 5 to 10. All grades, it could be minor. I have high cholesterol levels, that would count as one. And then those red and blue bars, the difference is not really that important. That represents the cancer population, the cancer survivors. So they're up around 15 to 20 if you add up all of their problems of all grades. So what happens if you only count the severe types? This is what happens. So the control, again, is that black dotted line at the bottom, and that number is about 2. So the average 50-year-old has 2 severe health conditions. The average cancer survivor is more than that. It's double to triple the amount of severe healthcare conditions. So these are consequences to treatments that people have gotten decades ago. And the hope is, the crystal ball is telling me, You repeat the study in 10 years, the difference is going to be smaller. But now we have 500,000 people who are dealing with the consequences of the treatment they got when they were younger. So don't worry about this graph, I'll explain it. What are those problems? What are those problems? So the way these graphs work, there's two of them. On your left-hand side is going to be the severe side effects. On the right-hand side is all of them. And then you can see that each triplet, there's a triplet of bars, and those represent different diseases. And on the far left is controls. So when those bars are low, you have less side effects. When those bars go up, you have more side effects and more health conditions. And each color represents a different organ system that the patients are dealing with. And the two most common long-term late effects for cancer survivors in pediatrics are heart toxicity and other cancers in the future, which we also heard earlier is a huge problem and drives the need for survivorship clinics and continuity of care. And this whole transition of care after you've been treated for cancer is a huge problem everywhere because you don't quite fit in anywhere. The oncologist is not treating a cancer anymore, so you go somewhere else. You go back to your primary. You graduated, congratulations, but you're still living with the scars of the past of what you've been treated with, and you need somebody with some knowledge about what you received to interpret your symptoms. So cancer docs don't want you. Primary care docs feel like they're in over their head, and they don't know what to do or how to help people out. So it's a gap. Heart disease and other types of cancers, those are the primary two. I am doing good on time. Everybody, this is a COVID-related question because I've been getting it a lot over the past couple of years and what COVID has done in pediatric cancer. And so I got involved with this study. My name is in the middle somewhere because I didn't write it. I just participated in it and gave some advice about how this should look. One question I get is, did you see a change in your cancer rates, delays in diagnoses or more diagnoses? And happily, I can tell you no, at least not yet. Our numbers of cancer patients, pediatric cancer patients at the University of Iowa, our service diagnosed between 1 and 2 new patients per week. Every week, once or twice, somebody on my team or myself is telling a family their child has cancer, and I don't know why, because they keep asking every week. So that's what's motivating me to be here. I want to answer those questions. So after 20 years of practice, I can tell you the best way to treat cancer is to not get it in the first place. There's no way around that right now. So COVID hasn't really changed our statistics or the rate with which people have come in or more advanced stages. It might be the nature of pediatric cancer. When your kid is sick, maybe it drives you a little bit differently than if you have a lump or a bump somewhere and you kind of ignore it for a while as an adult. Parents behave a little bit differently. But what happened to children who got diagnosed with cancer in COVID? And this goes back to the very beginning. If you remember, March of 2020, which I think was the first time cases in Iowa were discovered, all sorts of questions were coming up through that long and dark year. So what happened to our patients? So we had about a 5 to 7%, across the country, by the way. This is like over 1,000 patients across the country that were involved in this study. 5 to 7% of them went to the ICU. This MISC is that inflammatory syndrome that you might have heard about, where your just immune system goes bonkers when you get COVID. So that happened about 1 to 2%. Ultimately, death was the most important variable that a patient would be asking. What's the chance that my child will die because they got COVID and you're treating them for cancer? That number is somewhere between 2 and 4%. It can be a little bit hard to figure out when a child with cancer dies. Was it from COVID? Was it from advanced cancer? So we have some debate about making an attribution there. That number is 100 times more than general pediatrics. So when I tried to send my kids into the environment and into the society as much as we could, dating back to 2020, and still now, and now we have the other viruses to worry about, as people have probably heard on the news, RSV, and there's a ton of things going around that also can impact kids. So when you're talking about the burden of cancer, that also includes the risk that you're going to pick up something that a lot of people can get, but it's more likely to kill you. Because if you die of COVID, you're still not alive. And you may have died of COVID because your immune system is low. 2 to 4%, 100 times general pediatrics. So that's what people ask me. But here's the question that I ask myself that keeps me up at night. Change in therapy. So the dark days of 2020, COVID is out there. People are losing their minds. Child gets diagnosed with cancer. They're losing their mind from that anyway. And now you have both. It's frightening. It was frightening. So a lot of people were not sure, and still aren't, what do I do with my treatment? I don't want this child to die of COVID, and I don't want them to die of cancer. Do I keep going with my treatment? Do I modify it somehow? Nobody knew. And so we asked those questions on this survey, which is of the oncologist, did you change your treatment because that child got diagnosed with COVID? And the answer was 40% of the time, yes. Somebody got inferior chemo, something considered less, out of fear that you were going to unintentionally contribute to the death of the child because your chemotherapy was making them more prone to getting a bad COVID outcome. And that is what keeps me up, because I don't know what impact that had. It's still to be determined. It's still being studied right now. For all those kids, 40% of over 1,000 kids that had their therapy changed because they had COVID. Are they going to do worse? Are they going to be more likely to die of cancer? Nobody knows. So when you immerse these children into our society with all the dynamics that we talk about, there are inevitable realities that they have to deal with, that we have to deal with, that makes cancer burden not just about any one particular aspect. Can I prevent it? Can I do genetic counseling? It's surviving your cancer journey in everything that entails. So my two ending points of actionable items of what we can do as a cancer consortium about pediatric cancer. One of them is to utilize this wonderful network of people and say, you know what, I heard you talk about genetic testing in newborns. I think that if you insert these 11 genes onto your panel, advocate for that to be a routine, that you can save lives or at least reduce the burden of cancers, because there are some cancers, if I detect early, will be more curable and potentially not exposed to the chemo. So engaging in with those advocates is one clear thing I think we can do together to improve the outcomes. And the second one, for adult cancer prevention, engage with your local communities, your pediatric providers, because they're the ones who have the ear of the families. And it's not 100% of them that are going to buy into all of the recommendations, but at least as somebody who's positioned in your community with your patients to send healthcare messaging and address things like vaccine hesitancy or a struggling parent who just doesn't have the right resources or knowledge to to train their children in a healthy lifestyle, that if each one of you engaged with somebody who's caring for those children, that teaching them early might have a benefit by the time they hit adults. And on that note, I will thank you for your attention and be happy to answer any questions.
Thank you. All right, we got about 5 minutes for some questions. I don't know if I have one. I don't know if 5 minutes is enough for this topic, so maybe your 30-second elevator speech. So we had a group a while back through the Cancer Consortium talking about pediatric cancer, and it became really clear you can't talk about pediatric cancer without mentioning AYAs. Do you want to give a Cliff Notes version of some challenges with adolescent and young adult cancer patients?
Sure. So AYA, adolescent young adults, about 20 years ago, it was identified that this was a particularly vulnerable population because they fell into a gap in our systems. If you're 18 and a half and you're out in the community, where do you send them? Do you send them to adult oncologists or medical oncologists? And at about the same time, they studied trends over time with cancer care. In all age groups, in the younger side and the older side, and we saw a slide on this earlier, we have seen significant improvements in cancer outcomes. What's the chance you're going to survive your cancer? All age groups improved, except the AYA population. This is traditionally defined as age 15 to 39. That age group, over the past few decades, has, depending on which study you read, either shown zero or marginal, like razor-thin improvements in cure rates over the past few decades, and nobody knows why. That's the AYA gap, that's the AYA problem. We are fortunate, there are very specific groups that are aimed at addressing this issue. We are poised well at the University of Iowa with collaboration with the medical oncologists and pediatric oncologists to address some of these issues, and we have resources and a generous community that has supported that kind of effort in a program to recognize that patient population is unique, has unique needs. Forget about all the medical stuff, there's psychosocial stuff and emotional stuff, there's family planning and oncofertility issues which hit a little bit differently when you're in that age group than when you're at the extremes that need to be addressed in a very specific and unique way. So I think there are resources for AYAs, and you're right, it kind of is pediatric, it kind of isn't medical, which is part of the problem. But I feel fortunate that we have a community that supports that kind of work where we're at.
Thank you. All right, any other questions? Yes.
You mentioned the 40% change in therapy if they had COVID. Did that mean that they stopped like chemotherapy or like didn't finish the course of treatment?
Usually it was delay, pause, dose reduce. In some way, people were inclined to give the immune system a break when you were finding COVID, and that's why the concern is that potentially, we don't know this yet, you increase the risk of relapse by doing that. And you do it with the right intent to try and prevent death in the moment, because then you don't have an outcome to worry about if you lose a child to COVID. We've been very fortunate. We are being a part of that study, tracked all of our cases and continue to track with all the new variants. We're somewhere between 50 and 60 of our patients who have been diagnosed with COVID since the beginning of all of this stuff. We diagnose at our site, it's probably about 90 patients a year. So out of those 50 to 60, we haven't sent anybody to the ICU. Nobody's died. 2 obese adolescents needed some oxygen on the floor. But there are some patients who are picked up on asymptomatic screening. It's just like in general pediatrics. And I think in this case, I'm more lucky than good. I don't know that, definitely in 2020, we didn't have any resources. If you got it, we just kind of watched and waited. Now we have a lot more therapeutic interventions available to us. Certain people have been vaccinated. We're studying whether vaccination in people with cancer uptakes. It's a little unclear if the immune system can respond in the same way. So that's a current study that's going on right now. So I don't know if all those vaccinated kids are as protected as we think they are, because we kind of blow their immune system apart with the chemo. but it's introduced a whole variable. In addition to all the other variables, everybody's workforce distancing and no conferences, and we split the teams apart so COVID didn't get on our floor, knock all of us out as healthcare providers, get us quarantined. We had to come to work through the whole thing. I've been face to shield with COVID for hours of conversations with people who had COVID. And we've been very fortunate with precautionary measures that are available online. There have been pockets in a healthcare setting where workplace spread happened, but we didn't hear it because we scrambled to at least not be decimated as healthcare providers. Emotionally and psychologically, people are pretty decimated, but we protected each other in lots of smart ways.
All right, well, thank you so much for your great presentation and all your great work for Iowa's kids. We really appreciate it.